right now, I mean, up to 70% of postmenopausal women are experiencing this really fundamental structural change in their bodies.
Yeah, a change that makes, just sitting down or walking or intimacy physically agonizing.
Exactly.
Yeah,
And yet barely a quarter of them will ever actually get treatment.
right. It's basically the definition of suffering in silence because it's invisible, right? So the very real severe discomfort just gets brushed aside as, just another unavoidable part of getting older.
Which is exactly why we're dragging this out of the shadows today for this deep dive. I mean, we've pulled together this massive stack of medical guidelines, clinical reviews, NHS materials, patient advocacy resources.
So much data.
Yeah, a ton of data just to cut through that science,
Yeah.
because we're on a very specific mission today to answer an absolutely crucial question for you, which is, can vaginal dryness from genitourinary syndrome of menopause, or GSM, actually cause pain with penetration?
Right. And our goal here is to really arm you with the biological facts. Like, this isn't about vague, patronizing advice.
No, definitely not.
We are going to break down the deep mechanical realities of what is actually happening inside the body so you can understand exactly why this pain occurs and, more importantly, why you do not have to just, put up with it.
Okay, so let's unpack this, because before we can get to how GSM causes pain, we really have to clear up what it actually is.
Yeah, the terminology is a bit of a mess.
It's a total maze. Like, looking through the stack of literature, historically, the medical community used names like atrophic vaginitis or vulvovaginal atrophy, VVA.
Right, VVA.
But now, everything points to genitourinary syndrome of menopause, so GSM as the preferred umbrella term. Why the constant rebranding?
Well, the shift in terminology really reflects I guess you'd call it a belated wake-up call in the medical community because terms like atrophic vaginitis were actually highly problematic.
How so?
So atrophy means a wasting away of tissue, which, okay, that is accurate. But adding vaginitis implies like an active infection or inflammation.
Well, right, like an itis usually means infection.
Exactly, and that just isn't the root cause here. So then they moved to vulvovaginal atrophy, which was better, but it completely ignored a massive part of the anatomy that is equally affected.
The urinary tract.
Yes. So around 2014, the consensus shifted to GSM because it explicitly ties together the genital symptoms, so affecting the vagina and vulva and the urinary symptoms. It links all of this chaos directly back to its singular root cause, which is a postmenopausal state of low estrogen.
Okay, so to help visualize what estrogen is actually doing down there, I kept coming back to this analogy while reading the sources.
Okay, let's hear it.
Think of estrogen as like the scaffolding and irrigation system for the entire pelvic region.
Oh, that's actually the perfect way to look at it because during the reproductive years, estrogen acts as, the master architect.
The scaffolding.
Right. It keeps the vaginal lining, the epithelium thick, resilient, and really rich in blood supply. And under the influence of estrogen, this tissue is highly rugated.
Rugated.
Yeah, meaning it has these deep, stretchy, accordion-like folds. And those folds allow it to safely expand and contract.
So it's built specifically for elasticity.
Exactly. And then your irrigation analogy covers the other half of estrogen's job.
Okay, how so?
So estrogen signals those thick vaginal cells to produce and store glycogen. As the surface layers of those cells naturally shed over time, they release that glycogen directly into the vaginal canal.
And that does what exactly?
It provides a constant, highly reliable food source for the local good bacteria, specifically the lactobacilli.
Oh, the lactobacilli, so they're like the maintenance crew.
Yeah, exactly, the maintenance crew. They consume the glycogen and produce lactic acid, which keeps the whole vaginal environment perfectly acidic, usually sitting at a pH of like less than 4.5.
Wow, that's pretty acidic.
It is, and that acidity is your primary built-in shield against outside infections. It's just this self-sustaining, beautifully balanced ecosystem.
But then, and here's the estrogen drops. The scaffolding collapses and the irrigation gets shut off.
Right.
And for you listening, it's really, really important to note that this drop doesn't just happen during natural menopause, which, hits around age 51 on average.
No, the timeline can vary wildly. I mean, the same structural collapse happens during surgical menopause, like if the ovaries are removed.
Right.
It happens during breast cancer treatments that use anti-estrogen medications or chemotherapy. We even see temporary versions of this drop during breastfeeding or when someone is using certain progestogen-only contraceptives.
Wow. And the physical aftermath of that drop is just stark. Without estrogen, The tissue undergoes this fundamental structural downgrade.
It really does. It loses collagen and elastin. Those stretchy accordion-like folds, the rugae we talked about, they literally flatten out.
The scaffolding collapses.
Exactly. The tissue becomes incredibly thin, it pales in color because there's a severe reduction in blood flow, and it just loses all its vital elasticity.
In reading the clinical reviews, if you look at this transition under a microscope, it's startling. I mean, before the drop, you have these robust, thick layers of protective surface cells.
But after the drop, the lining thins out so dramatically that the deeper, highly fragile tissue layers are suddenly exposed right to the surface.
And the glycogen disappears.
Right, the glycogen is gone, so the lactobacilli starve and die off. The pH shifts from acidic to alkaline, and the entire area basically becomes an open door for inflammation.
Which brings us to the core mission of our deep dive today. How this structural downgrade translates into severe pain during penetration.
Yes.
But wait, I need to push back on something here.
Okay, go for it.
If the primary issue is that the irrigation system is shut off and the environment is just dry, wouldn't standard, over-the-counter lubrication fix this? Like, why are so many people reporting such severe, agonizing pain if it's really just a matter of friction?
Because it is absolutely not just a matter of friction.
Right.
What's fascinating here, well, actually horrifying, is that this is one of the most damaging misconceptions about GSM. The pain is fundamentally structural. Yes. Because the tissue has literally thinned out and lost its thick protective layers, it is incredibly fragile. We call it friable tissue.
Friable.
Yeah. So when you introduce penetration into an environment that fragile, it doesn't just cause an uncomfortable rubbing sensation, it causes actual physical microcuts, tearing and fissuring of the vaginal wall.
Wait, so the tissue is literally breaking?
It is tearing. The tissue can become so raw and compromised that it actively bleeds, which is why postcoital bleeding, so bleeding after intimacy, is such a common and alarming red flag for GSM.
Wow. And the clinical term for this painful sex is dyspareunia. And looking at the sources, it manifests in two very distinct ways, depending on what part of the anatomy is taking the hit.
Right, and pinpointing the type of pain helps confirm what's actually happening mechanically.
So what's the first one?
The first is superficial dyspareunia. This is pain localized right at the vaginal entrance, the introitus. Patients frequently describe it as a really sharp, intense burning or tearing sensation. The exact millisecond penetration is attempted. It's a highly acute, immediate pain right at the opening.
Well, deep dyspareunia is a completely different sensation.
Yeah, with deep dyspareunia, the pain is felt much deeper in the pelvis during thrusting, usually presenting as like a sharp or dull ache.
Now, I read that deep pelvic pain can sometimes point to other issues, right? Like endometriosis.
It can, absolutely. But in the context of GSM, it's a matter of architectural shrinkage. Because the vaginal canal has lost its stretchy scaffolding and flattened out, it physically narrows and shortens.
So it's literally smaller.
Yes. Penetration simply hits physical limits much sooner, forcefully stretching tissue that just no longer has the capacity to stretch.
And this mechanical trauma leads directly to what I think is honestly the most devastating aspect of this entire condition, the vaginismus cycle.
Oh, absolutely. It's a brutal cycle.
Because we have this physical tearing happening, right? But that triggers an incredibly powerful autonomous loop between the brain and the body.
Exactly. When physical intimacy consistently results in tearing, burning, and bleeding, your brain very, very quickly learns to associate that specific activity with severe trauma.
It's just classical conditioning. I mean, the brain is doing its job. It's trying to protect the body from a known threat.
Right. And the way the brain protects the body in this scenario is by sending an emergency signal to the pelvic floor muscles to just lock down.
Wow.
This causes an involuntary muscle spasm, which is vaginismus. For the listener, the sensation is often described as a partner suddenly hitting a wall just inside the vaginal entrance. The muscles clamp shut with such force that penetrative sex becomes physically impossible.
And you can't just, pour a glass of wine and relax your way out of a vaginismus spasm.
No, not at all.
It's an involuntary reflex, like pulling your hand away from a hot stove.
You cannot consciously override it in the moment. And if we pull back and look at the broader implications of this reflex, it completely reframes the whole narrative around libido and menopause.
Oh, this part makes me so frustrated for all the women who report a loss of sex drive during menopause and are just told, well, your hormones are changing. It's totally natural to lose interest.
It is incredibly dismissive. I mean, look at the mechanical reality we just walked through.
Right.
If every single time you attempt intimacy, it results in physical tearing, bleeding, and involuntary muscle spasms that make the act impossible, of course your libido vanishes.
Yeah, obviously.
A loss of sex drive in the presence of GSM is not some mysterious fading of desire. It is a highly rational biological defense mechanism against severe physical pain. The body is purposefully shutting down the drive for an activity it knows will cause architectural damage.
Which makes the statistics surrounding this condition absolutely staggering. Here's where it gets really interesting, because we're talking about a condition that causes tearing, bleeding, and complete muscle lockdown.
Yeah.
It fundamentally disrupts a person's life and relationships.
Yep.
And the data shows that GSM symptoms affect up to 70% of postmenopausal women. 70%.
It's a huge number.
Yet only about 7 to 25% are actually receiving treatment.
The gap between the number of people suffering and the number of people getting help is just a massive failure in care.
It's hard not to conclude that the medical community and society in general has effectively gaslit women into thinking this agony is just a standard, expected part of the aging process.
Well, the literature explicitly acknowledges this failure. I mean, for generations, the prevailing attitude, even among healthcare providers, has been that urogenital discomfort is just, your lot in life once you pass a certain age.
Right. Just deal with it.
Exactly. And patients often don't volunteer the information because there is so much misplaced shame and embarrassment. And a shocking percentage of doctors admit they simply never ask their patients if they're experiencing vaginal dryness or pain.
And what makes that silence even worse is that the impact of GSM doesn't clock out when you leave the bedroom.
Oh, definitely not. Like, if you're not sexually active, it's easy to assume this condition doesn't apply to you. But the reality of having tissue this fragile means it impacts the most mundane aspects of daily life.
Because the tissue is incredibly thin and lacks its protective barrier, every day, baseline friction becomes a source of pain.
Wow.
Women with advanced GSM report severe discomfort simply from sitting in a chair for a long time, riding a bicycle, wearing tight jeans, or even just the basic friction of wiping with toilet paper after using the bathroom.
That sounds miserable.
It is. The microabrasions occur just from moving through the world.
And because this structural collapse isn't geographically isolated, it spreads right next door to the bladder. We really have to talk about the U in GSM, the urinary symptoms.
Right. The urinary tract and the lower vagina are anatomically and developmentally inseparable. The urethra, the tube that carries urine out of the body, and the trigone, which is the base of the bladder, actually share the exact same embryonic origins as the lower vagina.
Wait, really?
Yes, which means they're also absolutely packed with estrogen receptors. Oh, so when the estrogen scaffolding collapses in the vagina, it takes down the bladder and urethra with it.
Exactly. The tissues of the urinary tract thin out too. They lose their elasticity, and the smooth muscle support atrophies. This triggers a whole cascade of urinary misery.
Like what?
Chronic urinary frequency, sudden and intense urgency, and stress incontinence, where simple things like coughing, laughing, or sneezing cause leakage.
And then there are the UTIs. Recurrent urinary tract infections are a hallmark symptom. But reading the sources, there's a really important distinction here between a true bacterial infection and symptoms that just mimic an infection.
Yes, this is a vital piece of the puzzle for anyone listening who feels like they are trapped in a cycle of constant UTIs, but, their doctor keeps telling them their lab cultures are coming back negative for bacteria.
Right, the fake UPIs.
Think about the physical state of the tissue. You have a vaginal opening and urethra that are incredibly thin, raw, and covered in microscopic tears.
Okay.
When normal, naturally acidic urine passes over those open microwounds, it burns fiercely.
So it feels exactly like the agonizing urination of a UTI.
It perfectly mimics dysuria painful urination. But it isn't a bacterial infection. It is literally just urine irritating open atrophic wounds.
Ouch.
Yeah. Now, that being said, because the local ecosystem has collapsed and you've lost the protective acidity of the lactobacilli, you are also at a genuinely much higher risk for actual bacterial UTIs.
So it's an exhausting double-edged sword.
Complete.
Okay, so we've laid out the biological reality. The collapsed scaffolding, the fragile tissue, the muscle spasms, the agonizing urinary symptoms, and the systemic gaslighting that leaves millions untreated. So what does this all mean? What is the actual roadmap out of this?
Well, the great overarching message in all of this data is that GSM is highly, highly treatable.
That's the good news.
It is one of the most successfully manageable conditions in this phase of life. The clinical goal is very straightforward. restore the urogenital physiology, and alleviate the symptoms. And there is a very clear evidence-based ladder of interventions to get there.
Okay, let's start with the immediate non-hormonal options. When looking at the difference between moisturizers and lubricants in the sources, I keep picturing like a skincare routine.
Ooh, I like that.
So is a vaginal moisturizer essentially a daily face cream used for long-term tissue health, while a lubricant is like a raincoat you only throw on when you need immediate situational protection, like right before intimacy?
The face cream and raincoat analogy holds up perfectly. Vaginal moisturizers are formulated for routine, ongoing use, usually applied, several times a week.
Okay.
They are meant to be absorbed deep into the tissue to restore moisture balance, help regulate the local pH, and provide long-term daily comfort. You use them regardless of whether you're sexually active that day.
And the lubricants are the raincoat.
Exactly. Lubricants are purely situational. They sit on the surface of the tissue specifically to reduce friction during sexual activity or like pelvic exams. But a major caveat for the listener: the specific products you choose matter immensely. For lubricants, you want to stick exclusively to water-soluble or silicone-based options. And if you're relying on latex condoms, oil-based lubricants are strictly off the table.
Because they break down the latex.
Right, they will rapidly degrade and break the latex.
There are also strict warnings in the text about the ingredient lists for both moisturizers and lubes.
Oh, yes.
Like if your tissue is already fragile and micro-tearing, the last thing you want to do is introduce chemical irritants. So the sources say avoid anything with added flavors, sugars, warming, or tingling properties.
Which are so common, sadly.
Yeah. And stay far away from chemical preservatives like propylene glycol or parabens. They will only exacerbate the burning.
Definitely. But if the non-hormonal moisturizers and lubricants aren't enough to resolve the pain, which is incredibly common if the structural atrophy is really advanced, we move up the ladder to hormonal treatments.
Okay.
And the gold standard here is localized topical estrogen.
Wait, I need to pause you there. Because the second I hear the words estrogen therapy, my mind immediately goes to the systemic risks we always hear about. Blood clots, stroke, breast cancer risks associated with oral HRT pills that circulate through the entire body.
Sure.
Are we telling listeners to just ignore those risks?
It is a completely understandable fear, but we really have to separate systemic HRT from localized estrogen. They operate entirely differently.
Oh, so.
Localized estrogen is delivered directly to the vaginal tissue. It doesn't go through your digestive tract or flood your systemic bloodstream.
So it goes right to the site of the collapsed scaffolding.
Exactly where it is needed. It's administered via a cream, a pessary, which is a tiny dissolving tablet like Vagifem, or a flexible silicone ring like Estring, that sits in the upper vagina and releases a microscopic, steady dose of estrogen over 90 days.
Okay.
Because the dose is so incredibly low, only a clinically insignificant amount ever enters your main bloodstream.
So it bypasses the systemic risks and just does local repairs.
It goes straight to work locally. It signals the tissue to rebuild collagen. It restores the stretchy rugae. It physically thickens the epithelium. And it triggers the glycogen production that brings back the good lactobacilli bacteria.
Wow, so it literally reverses the structural atrophy.
It cures the mechanical root cause of the pain.
Mm-hmm.
It is so low risk that even women who have a history of breast cancer are frequently cleared to use it, in consultation with their oncologists, of course.
And if someone still isn't comfortable with or isn't a candidate for topical estrogen, the sources did mention other medical avenues.
Yeah, there are several non-estrogen or alternative pathways. Ospemifene is a daily oral pill. It's a non-estrogen medication that binds to estrogen receptors specifically in the vaginal tissue to mimic estrogen's positive thickening effects.
Oh, that's clever.
There are also DHEA inserts, which provide a precursor hormone that the vaginal cells locally convert into both estrogen and testosterone. And if the primary barrier is just the initial agonizing entry pain, a doctor can prescribe a topical lidocaine ointment to simply numb the opening right before intimacy.
But hold on, we established earlier that the pain triggers a secondary problem, the vaginismus cycle.
Yes.
Hormones and face creams are going to rebuild the tissue architecture, sure. But they aren't going to instantly erase a learned muscle reflex, are they?
No, they absolutely will not. This raises an important question, right? Because if your brain has hardwired that fear spasm loop, Fixing the tissue is really only half the battle.
Right.
You have to address the musculature, which requires physical interventions alongside the medical ones. This is exactly where pelvic floor physical therapy becomes a critical part of the treatment plan.
Which is essentially targeted physiotherapy for the internal muscles of the pelvis.
Exactly. A specialized pelvic floor physical therapist can physically assess the tension and teach you how to consciously identify and relax those locked muscles. They work to break that involuntary reflex.
And another major tool in this physical rehabilitation mentioned in the texts is the use of vaginal dilators.
Yes.
These are those smooth, graduated cylinders used to gently stretch the tissue, right?
Right. They're used progressively. They help safely stretch vaginal tissue that has narrowed and shortened. But honestly, more importantly, they are a training tool for the nervous system.
Oh, interesting.
They allow the brain and the pelvic floor muscles to experience penetration in a controlled, completely safe environment, retraining them to accept insertion without spasming.
And there is one final physical intervention heavily featured in the clinical texts that might catch people off guard, but mechanically it actually makes perfect biological sense.
Oh, you mean regular sexual stimulation?
Yes.
Yeah.
It is the literal definition of use it or lose it. I mean, the clinical data strongly emphasizes that regular sexual activity, whether that involves a partner or is solo, is actively vital for maintaining vaginal health.
Absolutely.
Specifically, I was fascinated to see vibrators clinically recommended in the urogynecology literature.
They are highly recommended. Utilizing a vibrator a few times a week is literally prescribed physical therapy for this condition.
Wow.
The targeted vibration stimulates intense, localized blood flow directly to the pelvic region, and that rush of blood brings oxygen and vital nutrients, which mechanically helps keep the vaginal tissues healthy, elastic, and functional. It maintains the architecture.
So to pull all of this together for the listener, can vaginal dryness from genitourinary syndrome of menopause cause pain with penetration? The answer is an undeniable, resounding yes.
Absolutely, yes.
It is not just a lubrication issue. It is a profound structural collapse caused by a drop in estrogen, leading to the literal mechanical tearing of fragile tissues and secondary involuntary muscle spasms.
The pain is real, the structural damage is real, but, the most vital takeaway is that GSM is highly, highly treatable.
Right.
You have a full spectrum of options, from high-quality daily moisturizers to localized, low-dose estrogen that actually rebuilds the tissue to targeted physical therapy. This is not a moral failing. It is not just an inevitable consequence of aging, and honestly, no one should feel pressured to just suffer through it.
Which leaves us with a final thought to ponder. We started this deep dive noting how society ignores the invisible structural shifts in our bodies. But knowing what we know now, that the medical community explicitly recognizes regular sexual activity and masturbation as ways to draw vital blood flow to the pelvic region, preserving elasticity and preventing structural collapse.
Yeah.
Could we start viewing the prioritization of our own sexual pleasure not just as like a leisure activity, but as a literal prescribed form of preventative medicine and lifelong anatomical maintenance? Keep your scaffolding strong.
I mean, when you understand the biology, it truly becomes a medical imperative.
Thanks for diving deep with us.